Yes, we can start. It's
Okay, good evening, everyone. Thank you for joining us for this evening for our first episode of what's going to be a monthly webinar series on global and rural surgery talks. This is our first episode on access to safe surgery in rural India. I'll just give a brief about the idea behind it and then I'll introduce our eminent speaker for the evening. So, the idea for Scalpels and Society came out of a group of young and aspiring surgeons who were meeting together during a conference on rural surgery in Haldia, West Bengal last month, RCCon 2026. All of us, in our own way, are passionate about helping bridge the health inequity gap in our country, but we didn't know exactly where to start. So, we looked at each other and wondered, why don't we start with a webinar where we focus on the people who have contributed towards safe surgery in rural India and highlight that. So, out of that was born this idea for the webinar, and it's presented to you by the Rural Hospital Network. So, we're looking forward to presenting to you stalwarts who have been contributing to rural surgery for many years, creating impact which will last for years to come. Those of you who are interested in getting involved in global and rural surgery, either directly or indirectly, but don't know what it's like or where to begin, this webinar is for you. There are many misconceptions about rural surgery in India. I've heard juniors and seniors alike say that, oh, surgery in rural areas, it's substandard. But this is wholly untrue, and we're here to change that perception. So, our first speaker today evening is Dr. Nandakumar Menon, sir, who, in addition to being the surgeon co-founder of Gudalur Adivasi Hospital in the Nilgiris in Tamil Nadu, he's also been my mentor for over 4 years now, and he's one of the reasons that I became a surgeon. We fondly call him NK Sir. And whenever we interact, he never fails to amaze me about the ideas that he has for the future of healthcare and education in India. Sir is originally from Kerala, but he did his MBBS in CMC Vellore. During the interview, he was asked why he wants to become a doctor. His answer to them was to work for the poor. And that is something he has not wavered since. His professional career took him to the USA to complete his training in surgery. And in 1990, Sir made the decision to leave a comfortable surgical career in the US and move back to India. Not just India, but rural India, to serve the tribal people of the Nilgiris in Gudalur. That's 135 kilometers from the nearest airport, and at that time it had very limited road access to other facilities. Sir co-founded ASHWINI Gudalur Adivasi Hospital, and he was its director from 1990 to 2020. He is the recipient of the Paul Harrison Outstanding Alumnus Award 2005 from CMC Vellore, the Humanitarian Award from the American College of Surgeons in 2018, and he is a member of the steering committee of the National Health Mission of Government of India. He is married to Dr. Shaila Devi, a gynecologist, who is also a co-founder of Gudalur Adivasi Hospital, and they both live on a farm in Gudalur in Tamil Nadu. The Gudalur Adivasi Hospital was built by the tribal people for the tribal people. It is built to look like an Adivasi home, and it caters primarily to the Adivasis, a marginalized population that has historically had limited access to modern healthcare systems. This is an important takeaway in architecture. A hospital building should feel warm and welcoming to the patients, not stern or intimidating. The 20,000 odd tribals living in the Gudalur Valley belong to 4 different tribes, and they're all classified as primitive tribal groups. They are the Panyas, the Beta Kurumbas, the Mula Kurumbas, and the Katanayakans. So in the late 1980s, the tribal people had a meeting about how to deal with sick people who needed hospitalization. They faced discrimination in the government hospital, and many sick patients would just decide to lie outside their huts and just wait to die. It was decided that they needed a hospital for themselves. That's when they found NK Sir and Shaila ma'am, who themselves were looking for a rural hospital to work in. Established by ASHWINI, the Association for Health Welfare in the Nilgiris, the hospital now has 50 beds, 2 OTs with laparoscopic facilities, endoscopy, and 8 peripheral centers. With limited funds, the hospital uses interesting frugal innovations. Sir initially fashioned an OT with a homemade operating table and using natural light. They initially admitted patients with beds on the floor. They show us that working in rural areas require a high level of creativity. Early on, Sir noticed that patients would come commonly with joint pain and breathlessness, and he didn't know why. Eventually, he realized that the diagnosis was sickle cell disease, and based on this need, he set up a dedicated center in Gudalur with a blood bank. It's a lesson that we should adjust our actions according to the situation and not just rely on preconceived notions. NKSA and his team trained young tribals to be nurses, pharmacists, and lab techs. They also set up learning centers in villages. At first, the tribals were petrified of treating non tribals and they would run and hide behind NKSA. But with time, their confidence grew. Today, Ashwini is mainly run by the tribals themselves. They provide care and make most of the decisions in the hospital, which is something that has given them immense self esteem and standing in society. The improvements in healthcare indicators have been remarkable. The infant mortality rate in the region fell from 250 per thousand to less than 20 today. Surgeons like Dr. NK embody the true essence of holistic clinical care, creatively serving the multifaceted needs of the community, both in and beyond the operating room. Without further ado, we'll begin the questions for Sir. So it's just a reminder to the audience that this webinar is being recorded. So if you can please stay muted and you can type your questions in the chat box. We'll discuss this in the end of the session. Over to you, Sir. We'll start with the first question. So what was the turning point in your life that made you choose this path?
When I was a school student, we had a trip where we went to Haridwar, and I had a near-death experience in the Ganga there. And at that point, I decided that I would, if I got alive and wasn't drowned, I'd dedicate my life to service to other people. So that's how the whole idea of, um, of being of use to society grew.
And we wanted to know, Sir, what were the challenges you faced in the early days of starting work?
Well, first was to find a place to join. As Alicia said, we were fortunate to find a group that really were very underserved. And two of my juniors had actually started the community health work, and the people were looking for a hospital. So there were many challenges. In those days, it was very easy to start a hospital. All that you needed to do was put up a sign, and we got a rented building, and we started our work. The first issue was to have staff, and so we actually got just educated people up to class 6 or 7, those who could read and write in Tamil or Malayalam, to become the staff, and we trained them. They were just tribal people who were motivated to work for their community. So basically, that was a requirement, and they were then hands-on training in the hospital. So the first few, I would say the first year, we were mostly in the hospital. We slept at night, and my wife Shaila would teach them how to take deliveries, start IVs. So we were basically involved in training them with all the hands-on experience, and gradually they took over. Today they conduct most of the deliveries, and they know very well when uh, things are things are that the person needs a cesarean section or further treatment. So they're a group of intelligent people. It's only that they've never been given an opportunity to study and to move on in life. So that one of the challenges was to have the staff. And right from the beginning, we said it's going to be a tribal organization. So we identified youngsters and then trained them. So the second challenge was finances. We were very fortunate to always have someone support us with these individuals or foundations or trusts. And over these last 35 years, we've never had a situation where we were desperate in need of money when someone didn't come forward and help us. So I would say that these were the major challenges that we faced. Of course, there's always challenges every day with equipment and so on, but you learn to live with and deliver with whatever you have.
Can you tell us more about the early days with the OT that you use natural light with?
So when I was, my wife did her MD gynecology at Trivandrum Medical College, and while I was there, I joined as as a assistant professor. We were fortunate in those days to have the school officer. So they were very kind enough to let me get trained in all kinds of things. So I requested that we have anesthesia training, and I got 6 months of training in anesthesia. So we were quite adept in using the EMO machine, which uses ether and room air. And ether is a very good anesthetic. Its only problem is that it's inflammable. But that was not a problem for us because we were not using any cautery. So we used to have the laparotomies. I used to intubate the patient, put them on the EMO, and hand over to one of the nurses, and Shaila and I would do the surgery. So it was one has to adapt oneself to whatever is necessary, and one has to have the skills uh, to be able to address these issues. So after you finish your MS, if you were to go to a rural area, you need to be multi-skilled because you may not find all the necessary components uh, to do surgery. So you might have to do some amount of anesthesia. Spinal anesthesia, for example, is something that you should be very comfortable with because that's what most operations that we do will be under spinal and so on. So you have to actually figure out what is required and where you're going and adapt yourself to take extra training so that you can handle these situations. So in a rural area, obstetrics and surgery are two main things. General medicine, of course, but I think most of us can manage the cases as they come quite late to most of our centers. So I would say that the OT was a very small room that we had with a table that we could tilt up and down, and it was so small that we actually had to go under the table to reach the other end of the room. And at the end of the case, all of us had massive headaches from the ether because we didn't have any exhaust facility. But we just made do with whatever we had till we moved to a better operating room in a few years' time.
Okay. And can you discuss, sir, one story of a patient that you might have saved by being there at the right time in the right place, who may otherwise have died if they had been referred far away?
Yeah, very soon after we had this rented building I just described and the operating room, we got a patient who was referred from the government hospital, our Taluk hospital in Gudalur, and was asked to go to the Uti, the district hospital. But he came to us. He was a tribal who had been mauled by a bear, and he had multiple lacerations all over his body. And in the government hospital, they had actually cleaned and sutured all the wounds. And when he came to us, he was completely covered with all these different lacerations, all sutured. So we then took him to the operating room and started removing the sutures because you're not supposed to close dirty wounds. And while we were there, we heard a bubbling noise, and we realized that he had a puncture into his trachea, and they were actually slowly getting the secretions going into his lungs. So we fortunately he was placed in a spot that we could do a tracheostomy. So we had one metal tracheostomy tube, thankfully. And so we did a tracheostomy and put the tube in, and that had saved his life because if he went to Uti in the situation that he was in, we would have certainly died on the way. So that was one of the cases where we were fortunate enough to have all the instruments and the tools to do the tracheostomy. And that was the only tracheostomy tube. And this patient actually ran away back to the forest with our tube. So we lost the only tube we had, and we finally found him much later on and recovered. By that time, the tube was all gone. So that was a save that was in the early days.
And sir, can you tell us more about the decision of you first going to the US and then coming back to India and how you navigated that?
After I finished my MBBS, I actually got my MD general medicine seat. But then I realized that in those days, general medicine didn't have very much investigations and so on. So I was not very sure whether that's the right career choice before I ended up in a rural area. So I took a year off and went to a very well functioning rural hospital in a place called Ottanjatram in Tamil Nadu, where there were two surgeons, a pediatrician, a physician, and an obstetrician. So it was a very good team, and we had so many. I mean, it was a very busy place, and then I realized that surgery was very important. That you need to have surgical skills, and unlike medicine, you can't learn that from a book or by seeing patients. And you have to have someone has to teach you surgery. You have to go to the operating room, and somebody has to let you into the operating room, and you have to go through a course. So I realized that I had to get either an MS seat or to go abroad.
You had a
The
story.
problem in India today is that if you have an MS degree, you still take a number of years before you can actually be considered a respectable surgeon and make a decent income. So that I thought the simplest way was to go to the US. You can make money, get your degree, and then and take care of your family's financial and other needs, and then come back. So which is what I did. So I went there and got my degree, and I carried on working there as I finally reached the position of associate professor. And then by that time I had married, And fortunately, my wife was as excited as I was to go to a rural area. So we then decided to come back, and then she then pursued her MD General Medicine in Trivandrum, and then we found. I looked all over the country. I traveled quite a bit trying to find a place because in those days there was no internet, there was no way of figuring out where to go. So I actually went to many of the places where my seniors had gone and had discussions with them. And finally, I got this news from Gudalur that they wanted a hospital, and we ended up there.
So what did you find that are the three most critical non-surgical skills that you need that a young surgeon might need to survive in a rural area?
Yeah, you have to have some amount of administrative skills because you'll be dealing with quite a lot of people. You'll have to uh, have some idea of equipment, ordering equipment. You have to have some amount of financial knowledge. Uh, you also have to have quite a bit of networking and proposal writing to get the money required to run the institution. Of course, in my case, I was very fortunate since my wife was very interested in, or rather, she took over the responsibility of administration and a lot of the proposals, writing, and getting the money. Well, because I was totally focused on the patients, and fortunately, she took on all the rest. So you have to have a team. Uh, and for me, since I was a surgeon, I was fortunate to marry a gynecologist. So actually, and Shaila actually took up gynecology, took up obstetrics because she felt that that was the most important thing other than surgery. So you need to have a team. As you do as you work in a rural area, the team will actually start going around you as you start, as people start finding out there's a place where they can work, where there's a tremendous need. It's a need which actually attracts a lot of people to come and work and contribute towards a community's well-being. So I would say that those are the skills that you need to have, other than, of course, your medical skills.
There's also one question that's on a lot of people's minds that how do you navigate local superstitions? So if the patient's family are not willing to go ahead with a surgical
Right.
procedure or a modern medicine practice that you're advocating, how do you deal with that, sir?
But in our case, the institution had a lot of tribal staff, and very often the patient would be related or would know some member in the staff. So that would be very very helpful. So they would actually speak with the patient, and there's a question of trust. And once they speak and say that this is the best situation for you, that you have surgery, they're very very afraid of surgery. That's one of the reasons why they don't come to hospital, is that they say, oh, in the hospital they'll cut you up. So you need someone who you trust, and gradually over time they've started trusting us. So when we say that we need surgery, they realize that we have no other interest other than their best interests. So uh, our staff helps us, and very often we have conversations with other tribal members who will speak over the phone if necessary. Like recently with the mobile phones, we've actually talked to them, their friends in the villages, who convince them that they require the surgery. So I would say it's a strength of our community program and our relationship with the community.
I think you had an interesting story about a young woman who needed a cesarean section as well. You want to share that?
So this was the early days when we had gone to one of the villages on a routine visit, and there was this young lady who was quite short, and she was already in labor, and the baby wasn't coming out. So when we went there, she was surrounded by a whole bunch of women. This is a Beta Kurumba village. They're very supportive. The whole village comes together when someone has a baby. So all these women were looking and wondering what to do because she was not delivering. And at that time, we landed up. And I looked at her, and one look, even with my poor obstetric knowledge, I could see that this lady required a cesarean section. No question about it. So I asked him, where's the husband? That poor fellow had gone off because he didn't know what to do. He was trying to convince this lady to go to the hospital, and she wasn't going. So he was standing facing a wall. So I went to him and told him, this your wife needs to have surgery. So he said, what am I to do? She won't listen to any of us. So, so I went back and told the all the older ladies who were there that she has to go for surgery. They had a big discussion, and they said yes, she has to go to the hospital and she needs care there. So we carried the screaming lady because she said she was not going anywhere. So we carried her and put her into the jeep and took her and performed the surgery, and everything went off very well. Baby and mother went home, and a few weeks later, the same lady came back with her small newborn with a small upper respiratory infection, all the way from a village which is like 2 hours, at least 2 to 2.5 hours away. She had gained so much confidence and trust that we were able to solve a problem that it changed the whole way of thinking. So very often in villages where there is a dramatic change, for example, a patient who is given up for dead, for example, with tuberculosis, comes back after 1 or 2 months of stay in the hospital with anti-tuberculosis treatment, and they see the person alive and eating well, it changes the attitude of the village to say that yes, these people have medicines which are very good, and we should trust what they say.
Thank you for sharing that, sir. We'd like if you could tell us more about the sickle cell program as well and how you came up with that.
One of the strange things that happen when you work is that things happen in very very strange ways that you never anticipated. So when we started the work, we saw these patients who were jaundiced, and we were pretty clear that this is sickle cell disease, but we had no way of making a diagnosis. I'm talking about in the 90s when the diagnosis was quite difficult, and only very few centers were doing electrophoresis. So at that time, I took a break and went to the US because my family felt that I was not being fair to my children. And they said that you have to go. My daughter has some learning disabilities. So they felt that we should go to the US and check out things over there. So we took a hiatus and went off. And while I was there, I met just by chance, I met a young hematologist who was working uh, in one of the city hospitals in New York. And so we were discussing, and she said, "Why don't you come to our hospital? Our chief will definitely help teach you how to do electrophoresis and so on." So again, I went. So I went to their lab in New York City, and guess what? The two people in the lab were both Indians, and one and both of them said, "This is great. We'll teach you whatever we can." So the next week or 10 days, they showed me how to do electrophoresis. And then, so I was all set to go when they said, "But you don't have any of the equipment. What are you going to do going back to Gudalur without any of this equipment? You don't have the electrophoresis machine, none of these things." So the boss has an extra 220-volt machine that he used in Africa. Why don't you go and ask him for it? So I went to Dr. Nagel, who was the hematologist who was very well known in sickle cell circles. And I said, "I'm going back to India." So he asked me, "But do you have any equipment?" I said, "No." And I gave him the list that these two lab technicians had given me, a whole list of things. So he looked at the list and said, and he added a few more things. And he put a signature and said, "If I don't sign this, they won't let you out of the building. They'll say you're stealing all this." So I went back with all the equipment, came to India, and then I trained one of our lab techs to do electrophoresis. And ever since then, which is in 93 onwards, we were able to have the diagnosis. By 97, we were we were doing a whole lot of electrophoresis diagnosis. And then in the 2000s, the government started funding us our sickle program. So we did a village screening. And in 2000 and I think 14, we started newborn screening. So right now we have about 1% sickle cell disease in our population and about 15% sickle cell trait. Early diagnosis has been really useful in keeping them alive and free of crisis. And the other remarkable thing is that in our group, the under five deaths are very very low. As a matter of fact, we only had one under five death in the last 15 years since we did newborn screening. But we have deaths by the time they're 30, a good percentage of them die. So we still are way behind world standards for the lifespan of our patients. And many of them, although they take medicines, end up with recurrent crisis, and have organ damage and finally succumb to the disease. But till the age of about 28 or so, they have a fairly okay life because all their crises are being handled in the hospitals. We have a blood bank and they're on medications.
That's great, sir. And it's, I guess, one of the largest database Gudalur Adivasi Hospital has of sickle cell disease in the country, even more data than the government has. Right, sir?
But the government only recently started the whole, the sickle cell elimination program, and they are actually trying to get all the tribal and as well as the areas where the sickle is well known to get them all documented. So it's a huge enterprise. And now the government has actually started to do much more. And of course, with the government, it takes time for all this to reach the tribal people who are the most remote, in the remotest areas where the disease is. But it's also a non-tribal disease. Actually, as a matter of fact, there are more non-tribals with sickle cell disease than tribals. So it's not just a tribal disease. So it requires the government to continue the work and to provide all the medications at the PHC level itself, which is a huge challenge. And it's slowly the work is getting on.
Can you explain how the infrastructure for health facility also affects the delivery of healthcare, and any examples of innovations that you were used in your hospital?
The infrastructure will actually help you in providing more services. There's no question about that. If you don't have, for example, if you have a gastroscope, you can definitely make a diagnosis of CA esophagus, CA stomach, and that's very easy to do. If you don't have a gastroscope, then the person has to go all the way to a medical college to get the endoscopy done, because it's only being done by a DM gastro, which is crazy because it is so safe. Upper endoscopy is one of the safest procedures that you can do. We have done more than 4,000 without a single complication. Of course, we know our limitations. We only go and do a diagnostic procedure. We don't do anything more than that. Go and take a biopsy and come out. Nothing more than that. So it's a very safe procedure. And if you have that, then you can make a diagnosis much earlier. Because if you tell a patient to go all the way, for in our case, would be all the way to Coimbatore, which is almost 5 hours, or to Calicut Medical College, which is about 3.5 hours away. I mean, it's not done in the first sitting. You have to go there, then they'll ask you to come back again, and then they ask you to come back again the third time for the biopsy report. It doesn't happen. So most patients just drop out of the system. So having these kind of important uh, diagnostic tools is very, very important. For example, if you have a true cut needle, breast biopsy becomes so easy. It's just a 5 minute affair. You can have a biopsy done, and you can be in the day that you find the breast lump, you can get the biopsy. And then the next thing is to call the patient back just to explain what it is, and if it's malignancy, to talk about surgery. So definitely infrastructure increases the amount of services that you can provide. But that being said, one also has to, with whatever you have, one has to. If you don't have a true cut needle, then you have to use the whatever needle that you have and try to get a biopsy with it. It's not as easy, or you may have to take the person to the operating room and get a biopsy. So you have to do whatever it takes to get the diagnosis.
Yeah, on that note, I remember as an MBBS doctor working in Gudalur Adivasi Hospital, I was taught how to do endoscopies. So I think it's an essential skill. Definitely shouldn't just be reserved for gastroenterologists, maybe. So we want to ask you, sir, if a young surgeon is interested in rural surgery but may be afraid to leave cities for various reasons, what would you suggest to them that they should be doing?
Well, actually, the only time in life that you're free is the time right now, when you don't have family commitments and you're still you could be as free as a leaf that floats in the wind. You can go anywhere in the country, you can experiment, you can check out things. So a young surgeon should use this facility if he or she feels, the tug, and that I want to do something different, or I want to check out what's happening in rural areas, and feels that the inequity that exists in our society is so strong that I need to do something about it. Not that you're not performing service in a city. You are. But then, if you were not there in that position, how difficult would it be to fill up that spot? But within a few days, your vacancy would be filled. So if you look at a rural area, a surgeon makes a difference in a huge area. Sometimes as big as 100 or 200 kilometers, there will not be a single trained surgeon to perform ordinary surgeries. So you have to weigh if that tugs your heart and makes you feel that that's something useful. Also, this does not have to be a lifelong commitment. You can go and check it out, work there for a few months to see how it is, maybe take a year off and work in one of the more remote hospitals to see what it is like to be working in one of these centers. If it makes you happy and you feel more satisfied that you're providing services which otherwise these people would not have, if something like that, uh, if you start feeling like that, then maybe you will make a career change. But if you never stepped out of your urban environment and never did this, how would you ever know? maybe when you're in your 50s and 60s and you reflect in your life and you say, oh my gosh, I should have, at least tried it out. So just to get that out of your system, it might be a good thing just to see what's happening in some of these rural areas that are desperately looking uh, for skilled professionals, especially surgeons. Surgeons, gynecologists, and anesthetists are quite difficult to come by. The SAO, which is critical for our surgical procedures, it's very, very. In our country, the ratio is the numbers are so small. If you look at the number of such trained people in rural areas, it's really, really low. So you make a huge difference, not just to that hospital, but to that whole community. So something to get out of your system. I would say if you're not even that keen, I would still recommend doing it, because it's worth the effort. If just to check out what's happening in all these rural areas.
And so, would you suggest to join an NGO, or would it be better to work in a PHC or a CHC?
If you have a very good, well-functioning government system, that's very good. If you find an NGO which has a fair amount of surgery being done, it might be good to check out and see if you fit into it. The government side would be a little bit more difficult to get in because you have to go through the process of being selected and so on. So that's a long process. But for the NGOs, usually it's quite easy to offer your services. They'll grab you. I mean, it's so easy to go and join an NGO. So that might be the easier route to take, especially if you're just checking it out to see maybe a commitment for 6 months or 1 year, something like that.
We have a question from in the chat box by Rishikesh. Do you want to ask it yourself?
Uh, yeah. Hi. You described the makeshift initial OT that was in the tiny room. I wanted to know what were the usual cases that you operated or the
Yeah,
extent of
so
the
the
surgeries.
commonest cases would be under spinal, would be cesarean sections. We also did quite a few laparotomies for intestinal obstruction, for um, for blunt injuries to the abdomen. But mainly I would say that spinal was used much more than GA. Then occasionally gastric surgeries. You can do it under high spinal, but that's a little bit risky because the blood pressure really drops. So it's safer to do under GA. So we used to do in those days there used to be quite a few cases of peptic ulcer which we treated with gastrojejunostomies and perforations. Now of course that's all gone with PPIs. So uh, perforated ulcers, for example, was something that you could do under GA. You can do it under spinal also. It's depending on your patient. If he's quite a tough guy, then you could do it under spinal. But it's a little bit difficult to get the relaxation that you need.
What about the Bulgur injury, sir, that you operated on?
Yeah, so we have there'll be multiple soft tissue and abdominal injuries that we've had. So there were multiple injuries. Sometimes it's important for us to have adequate anesthesia to do a good examination. That's the other thing. So as time went on, we've actually got an anesthetist to help us with our surgeries. We're very fortunate to find someone who'd come all the way from an hour and a half away to help us with the cases. But in an emergency, it's difficult. You need to do something quickly, and then so we have to do a makeshift with whatever we have. If of course, as time goes on, patients are willing to go to a higher center. Now, for example, there's no need for us to get involved with pediatric, for example, imperforate anus. In the old days, we used to do a colostomy and so on, but now they're willing to go to a higher center. So where it's important for us to refer, we convince the patient, and our ambulance system, 108 system, is very, very good. They will take the patient to the nearest medical college, even across the border. They can go to Calicut Medical College, and they have a very good pediatric surgery department, for example. So where it's a complex surgery, where the person may require intubation for a day or two, because we don't have an ICU, we still have only a high dependency unit. So those kind of cases we refer out to the medical college.
We have a question from Divya.
Hi, sir. Hi, everyone. So I want to ask, the training in the US in those days was obviously very different from the surgical training in India. And also the healthcare system, I think, is still very, very different. Um, can you tell us about some of the challenges that you faced by navigating that system? And
controlled by us. So we had a whole lot of critical care, which was very, very useful when we came to Gudalur, because when we were quite comfortable with very sick patients. So that made a huge difference. The training in India, I think, should definitely be increased, because the problem right now is that in many centers the attending surgeons have their private patients who they operate on, and they are being paid outside in many of the institutions in the private sector as well as in many government hospitals. So the trainees are not actually given hands-on training to that extent. That is unfortunate, because when they come out, they still need to go to a hospital where they get lots more training. In the bigger hospitals at night, you get the emergency surgeries, but very often that's not. There is no one to guide you. You might be alone, or there might be someone who's just finished to help you. So these are the limitations we have. And the second thing is that when I trained, general surgery included orthopedics and urology. And in our hospital, we did not have any orthopedic residents, so we were the orthopedic residents. So we did a lot of fracture reductions. In urology, we did everything except TURPs. So we were quite competent in these fields, and those are very essential when you go to a rural area. You have to, I mean, fractures are a very common occurrence, and you have to reduce fractures using ketamine anesthesia or by some way to reduce the fracture. So I would say that that has changed. It's not so now. It's very much general surgery is now mostly the abdomen, and you rotate through the other systems. But in the abdomen, you have a lot more exposure in the sense that you have a lot more hands on. But then it's 5 years. So I would say those are the basic differences. In our system, we have a lot of private medical colleges where I do not know how much hands-on experience you get, because they're all their private patients.
Does anyone have any other questions from the audience?
Uh, when did you get an X-ray at Gudalur?
We got it when we moved to our actually our new hospital. So that would be somewhere in the 2000, I think 2010, I think. So we used to send them out for X. There was an X-ray in town, and we used to send them out for X-rays.
So was there a period when most of your operations were like most of your diagnosis was just on clinical grounds, even when an X-ray would have helped, or like how long was the period for the interim?
Yeah, actually, there was an X-ray. There was a private X-ray person in town, so we could get flattened upright abdomens and a chest X-ray. So that was available. Yeah, so we could get it, but it meant the patient had to be transferred out, and it's only much later that we got the X-ray facilities in our hospital with ultrasound and so on. So we were fortunate to get a big Tata grant, and we were able to upgrade the hospital. And at that time, we bought all the equipment, a lot of really upgrading, including the gastroscope that I spoke of. All that happened in the 2000s. So about 10 years after we had started work. The other thing which I'd like to point out is that with our system, it's very difficult to get further training. I mean, if you wanted to learn endoscopy, how would you go about it? Um, are there enough facilities where you get where there are people who let you train in these kind of things to increase your skills, especially if you want to go to a rural area? How many opportunities are there for further growth? Because we don't have anything called a rural surgery uh, PG program. The one that was there was discontinued. There was a DNB program for rural surgery that was discontinued. So it is really unfair asking people to go to a rural area and be a competent in all these different things unless we have a system by which a person who says that he's interested in going to a rural area gets exposure to orthopedics and urology and anesthesia, because very often they have to train their nurses to be the to monitor the patient. For example, we would have a nurse. So we would give the spinal and have a nurse take the blood pressure and tell us every in the initial first 10 minutes, every 2 minutes, what the BP was, and then move on to about 5 minutes. So you have to you have to have you have to have the training for these things to be certified in spinal anesthesia, for example, and for endoscopy. So someone has to teach you all these things. So we don't have a system in place. Although 70% of our population lives in rural areas, there isn't anything that the government has in place for those who are interested in gaining these skills, which is very unfortunate. Which is very, very unfortunate. And that's the reason why many doctors are reluctant to go there, because they know they'll be very much outside their comfort zone. They have to deal with all kinds of things, which is way beyond what they've been trained. So unless they are ready to take on that kind of responsibility and do whatever it takes, because the alternative to not do the surgery is for the person sometimes to just go home. They might refuse to go to the government hospital, and that's the case in many of our patients. They'll say that if you do the operation here, or I'm going home. As simple as that. So in that point in time, if you have a good textbook, you're basic surgeons. You look at the textbook and do what has to be done. You have the basic surgical skills. So you know the procedure, you just do it. I mean, suppose you have an injury and the kidney is injured and is bleeding and it's not stopping. You have to do a nephrectomy or a partial nephrectomy. Just do it, because the patient is not going to go anywhere. He's going to die. So, and very often, you learn by doing these procedures on your own. There's no option. There's absolutely no option. So these are the kind of things that one has to think about and steel oneself to that you'll be facing these kind of situations, and you should be ready to do whatever it takes.
On that note, sir, there's a question from Radhika saying, how do you think the rural surgery should progress from the current state that it's in? What is the future, sir?
There's a number of things that the government can easily do. One is that the MS program can include the district and taluk hospitals. In our country, unfortunately, we have this division of medical colleges called education, medical education, and everything else comes under public health. Why do we need the separation? Why can't the medical college and the district hospital and the taluk hospital be one system, where the apex is the medical college hospital, which is a teaching hospital, the research hospital, the one that provides all the SOPs, and then you are posted as a PG, not just for 3 months in a taluk hospital, but one year. In a taluk hospital, you'll be exposed to much more general stuff. There'll be much more general surgery. There'll be much more orthopedics, which can be done close reductions, and your rotation should be much more in those areas. Now, unfortunately, the professors don't want to come down to the taluk hospitals, and nor do the associate professors, because they have their private practice in these medical colleges. And if you notice how cleverly the medical colleges are placed in the cities, it's all in urban areas. You don't find any of our teachers and our professors going to any of the other hospitals and training people. It's not happening. How do you expect people to go and, if you're not exposed to these things, if you don't go to the rural areas, how are you ever going to go there? You're not comfortable. So the one simple thing they can do is to scrap this current system and have the medical college incorporated with the taluk hospital and the district hospital to have one system in place, and the PGs rotate and they perform surgeries. Now in the medical college they're stepping on each other's toes, trying to get cases, because the caseload not adequate for the PGs. Now, why don't they open it up? There's so much work to be done in taluk hospitals. If you send a third year, finally a PG to a taluk hospital, he can do so much stuff. So I think there's so much opportunity there, but then we have a system which is designed for the people in power to stay very comfortable in their city private practice and not go outside. And I think that is something which needs to change. But who's going to bring about this change? It's going to be you guys who are going to protest and and bring this up as being the only solution. The government has increased the number of medical colleges. Has that translated to more doctors in rural areas? No. Our ratio is appalling. We have 1 in 600, 600 doctors for every 1,000 uh, individuals, one doctor for every 600 individuals in urban areas, and it is one doctor for 6,000 or up to 20,000 people in rural areas. It's a massive difference. Massive. So the newly trained people, where are they going to go? They're going to go to the places that they're comfortable with, where they were trained, in the cities that they were trained, in their home cities. And they're going to go back there. Unless they've been pushed to go to rural areas and find, that working in those areas is very comfortable and is very satisfying because you're doing so much, you have opportunity to do so much. Then you learn the local area, you see what the local area is like, how are the villages around these areas, what are the opportunities for work, what are the good hospitals working in this area. How else will you be exposed? Tertiary care hospitals in India are only glorified secondary care hospitals. They are not really tertiary care hospitals. They do stuff that should be done in the taluk hospital. The taluk hospital is just referring cases. Why should they refer cases? They should be doing the cases right there and then with the PGs and with trained teachers, assistant professors and the associate professors will definitely be there. Then the system, then the medical college can concentrate on what they should be concentrating on, which is research and the high end surgery. They're not doing that now.
Yeah, Divya, go ahead.
Sir, that's also something that I wanted to talk about. What is the role of research in the rural area? Like talking about the sickle cell program, I think we got an idea about the huge database that's been collected over the years. The same way, I think um, combining the opportunity for uh, collecting data and having this huge population that we can learn from is also could also be an incentive for those who are so inclined.
Yeah.
Um, that was
You're
my
absolutely right, Divya. You're
thought on
absolutely
it.
right. So research is a very important component, and actually it improves clinical care. So we've started about 6 years ago. We started a research department, and we have quite a few publications in the last 10 years, I would say. In sickle, we have two publications in well regarded journals. One is on comprehensive care, and the second is on mortality. And we're working on publishing one on newborn a cohort of newborn screening patients. So there's a great opportunity for research in rural areas, and one has to develop the database. Of course, you need time. When we first started, there was no time for any of this. So in most of the Western countries, the professors and the associate professors have at least 1 or 2 days in the week where they concentrate on research. Here there is zero. How do you expect quality research to come out if people are not given time? So in a rural area where there's only one surgeon and there are very few people, research becomes very difficult. To collect the data and to sit and analyze it becomes quite difficult. So then one has to have a dedicated research department, which does all the legwork, and then the different like the surgeon or the physician or whoever else can then in collaboration with the research person uh, put the data together and write about it, which is sadly lacking in our country. There's very little data that's coming out of rural areas.
Rishikesh has a question.
Yeah, I have two questions actually, slightly related. So before you had an anesthetist at your hospital, like were there any medical legal issues or tussles that came up when you had to administer anesthesia yourself? And similar to it, like how in the changing decades that you have been here, and how can we justify a general surgeon stepping up and of obviously an emergency procedure that they do out of like a bleeding kidney in a laparotomy is fine, but for elective procedures or that are on the brink between super specialty division now? How can we justify it in a increasing world of litigation?
You're absolutely right. You're absolutely right. If you're living in an area where there's an anesthetist, there's no need for you to do it. You can always call the anesthetist. The only situation would be if the person is like you have to do a cesarean because there's severe distress. Then you have to do it because otherwise the baby is going to be the baby is going to die. So, so in that scenario, you're allowed to do a cesarean section. Now, you should be competent enough. You should have been trained in spinal anesthesia. Someone should train you, or you should get some kind of certification. Talking about spinal anesthesia, we have written a paper on a randomized study between an MD anesthesiologist and a trained medical officer. So we had a randomized study which we have published in BMJ Global Health, and after proper training and supervised spinal anesthesia, supervised by the MD anesthetist, the end result was that the medical officer was equal to the anesthetist. So this is one of the first randomized studies in for task sharing, this kind of thing which is essential in rural areas. So one of the problems is that where do we go? I mean, if I want to learn about spinal anesthesia, and I am in a situation where there is no one around, who is going to train me? We don't have nothing in our country for such kind of, and the anesthesia society is dead against it. They are dead against our, this research study was they were so upset that we were doing it. So we asked a simple question: okay, if you don't want us to do it, will you come and do it? Will you come and send an anesthetist to do it? If you can't send an anesthetist, what do you want us to do with our patient? And so that we've actually forced, the secretary of the anesthesia society was there, and we forced him to say yes. But you could see how reluctantly, it was like pulling teeth. He was so against it. So the societies are trying to maintain their turf, but they have the responsibility of anesthesia across the whole country, not just in urban areas. If they say that we should not give anesthesia in a rural area and they're not willing to come, then they should have a system in place so that they train people till an anesthetist is available. And that being said, if it's an elective case, there's no reason for you to do it in today's environment. If the patient is willing to go to a higher center, let him go. If you can organize a anesthetist to come there, that's fine. There's no need for you to get involved in today's world. As far as medical legal is concerned, ours is a community hospital. It's for the tribals. It's theirs. It is their hospital. So the question of having any litigation is it's not there. I mean, it's something that they won't even think of because the whole system is there to support them. If something happens, we just say that this is what happened and explain the situation to them, and that's the end of it. So we have not had a single case of anyone being upset with our care because everything is transparent. There's nothing for us to hide. So if there's a complication, we tell them this is what happened, and they say yes, these things can happen. And so we have a very good relationship with our community. So lawsuits, but you're right. In today's situation, you have to see where you are and the kind of scenario you are, and that you have the patient's full permission. So if the person doesn't want to go, then you have to have a written consent with witnesses saying that I don't want to go anywhere. I know that this person is not a specialist in anesthesia, but there is no other option. He knows how. He has been trained to do this. He's not an anesthetist, but he knows how to do spinal anesthesia. I'm okay with it. That is totally acceptable because the alternative is death. And let me tell you, there are lots of different parts of our country where this is happening. Anesthesia, spinal is not being given by even a doctor. There are all kinds of people who are giving spinal anesthesia, and it's totally uncontrolled in many of these remote hospitals. Why can't we make it legal? Why can't we make the whole thing, that people are trained? This is where the anesthesia society does not take the responsibility of the whole country. They should be. They should be responsible for anesthesia in these remote areas. What are people supposed to do there? They should have some programs training these people so that they give safe anesthesia. That is their duty. It is the government's duty, and it is the duty of the medical college to ensure these things. What else is the medical college for? They are the people who are sitting. They're the brains. They are the ones who should be analyzing the situation in their whole district that they comes under their jurisdiction. Otherwise, what is the point? Having all these very intelligent, capable people. What is their role in helping society? It's not just good enough to be great in your family practice and have a great name. I mean, no one's against that, but what about your duty to the larger population? I mean, they did not become these big shots because they were, of course they were intelligent, but they were pushed by so many determinants. I mean, they grew up in families where they had good education. I mean, there's so many things which got us to where we are. It is not that we were brilliant people and that we were geniuses and therefore we came. We were, lots of people have pushed us, helped us, invested in us. So what about the rural people who don't have those advantages? They should also be considered in the equation.
Very true, sir. We'll have the last two questions. Mayank, do you want to ask yourself or shall I read it out?
Sorry, Ajay, I missed that.
Mayank will be asking a question, sir.
Okay.
Okay, I'll read it out. He's asking how to make sure that even while working in a rural area, whether we are upskilling ourselves.
Yeah, it's all as I said before. There's a legal framework one has to work in. If, as I said, in today's situation, if you're in a place where you can refer patients, you should refer. To upskill, you have to spend time with surgeons who come and volunteer or who come to work in your hospital. For example, we have a urologist who comes and trains our junior surgeons on putting in stents. So after he has helped you with 10 or 20 stents, then he lets you do the procedure, and you're able to then proceed. Similarly, when we first got the endoscope, we didn't know how to do endoscopy. So I called up one of my friends who does endoscopies and asked him to come. He said, "You get 20 patients, and I'll teach you." So at that time, my son was a bonder. He was also a bonder in our hospital. So the two of us were his first students. So my son learned within 6 endoscopies. He said, "This guy can do it." I took about 10 cases before I could do it on my own. And he said, "You're certified. You go ahead and do these things." So if you have links with specialists who are willing to come and spend time and teach you, you can definitely upscale. And with today's, for example, in orthopedics now, we reduce the fractures. We send the films over WhatsApp, and we have two orthopedic surgeons who look at it and who tell us this is fine, or just redo it, or send this person for surgery. So we have to link ourselves with the specialists with the knowledge that we need, and then we can upscale our skills. Of course, there won't be any certification, but then if it's an area where there's no where are you going to find a urologist in a rural area? Even medical colleges, and they have vacancies, for example. So unless you train people in the rural areas to do these procedures, it's not going to get done. So because ureteric stones is such a common problem.
There's a question, sir, whether there's scope for a psychiatrist in the rural sector. I think it's from an aspiring psychiatrist.
We have a vacancy in our hospital right now. So you're all familiar with the Rural Hospital Network website. So we have more than 100 vacancies, and psychiatrists are very few. And mental illnesses are being recognized more and more now. So we need a lot more psychiatrists and counselors. Uh, and in rural areas, it's very difficult to find them. So most welcome. Who is somebody said, please apply right now to Adivasi Hospital. All the info is on our website, and please, we welcome you with the red carpet.
I think Ravi sir also had a question. Ravina?
Hello. Hi. NK, hi. How are you? Thanks. It's a beautiful session. I just have one question that I keep getting asked by NK because one is with the complex situation right now, a lot of young surgeons or youngsters have one is the lack of confidence to say, or some kind of insecurity as to whether they can manage complicated surgeries in a rural area. On the other side, there's the fear of these medical legal issues that's always scaring a lot of people. So, how do you advise uh, um, these young surgeons to look at how do they make a decision?
Yeah, I think they should look at centers like yours, where you are there, Ravi, and other centers like Alicia has gone to
Uh-huh.
Manali. They have to go and work with a senior surgeon if they feel that they need further encouragement, further training, and so on. Maybe they should upscale their skills because these hospitals do multiple procedures. The it's still the old-fashioned general surgery that is there. So if they want to get involved with other things, like I said, the orthopedics and urology and so on, maybe they should try and work in a center where there is a surgeon who's actually doing these things. So that's one way. Medical legally, I think, as I said before, it depends on your area. If there is nothing available in that area, there's no anesthetists, and it's an emergency, then and if you're well trained in it, you should do it. So the medical legal aspect of that is only comes in if there is already an anesthetist in the area and you're doing something that becomes unnecessary. So one has to see the situation in the particular place that you are. For example, I'm now in the northern Telangana, and right across the border, there is an area there with almost like 200 kilometers with nothing, where absolutely nothing. They don't even have a PHC.
Hmm.
It's unbelievable. It's just unbelievable. So I do, which is the
Wow.
organization I'm visiting. They're going to set up a small
Mm-hmm.
hospital there. Now you can imagine. Do you think there's going to be a medical legal case there? No chance. The people there are
Yeah.
tribals, and they have no access to anything. Now, for example, for you, Ravi, when you go up and you're starting a new hospital up in the hills, do you think you're going to get
Yeah.
cases, that medical legal cases
Yeah.
there? Very unlikely. Very,
Yeah.
very unlikely. Especially when you
Yeah.
have
So
the
NK,
community
yeah,
support you.
yeah. So yeah. So the thing is, it's also like how clear you are, or the spiritual. What do you say? The inner clarity that you have. No, because these answers, these questions, we don't have answers to, right? There's no going. Nobody's going to say, yo, there are not going to be any issues. But how do you from your no, I know you I mean, I enjoyed the wisdom that you have, about the spiritual strength or the inner strength. How do you deal with situations like this and all that, no? So
Ravi, I think
I'm,
a lot of it has to do with your relationship with the other doctors in your area and with the administration.
hmm
If they know that you're doing work which is, you're not there to make money or to get fame or any of those things, you're there to serve the people. They're also actually quite in a way they support you. um, so it's not you're not living in a kind of a vacuum where people don't know your activities. They know your activities, and any court of law would be on the side of an organization which has been working for so many years when the government was not nowhere in the scene. They were non-existent when you started. You and Reggie and Lalita started the work in Sitlingi. There was no one there. There's not a soul there.
yeah.
And then you have built up the thing. Now the government has these systems in place. At the same time, you're doing things which you've been doing for the last 20, 30 years. So
Mm.
it becomes an issue of how you deal with the patient. If the patient is the kind of person who you think might cause problems, it might be best not to get involved. If with them, they can refer them. If they got money and they want to go, they let them go. There's no reason for us to insist on the person having surgery. We have no axe to grind. If they want to go somewhere else, please go. So we can encourage them to go
Yeah.
if they have money and you think that they're going to create some problems for us. So one has to also be judicious in the way that we take our patients. If we feel that they can go
Yeah.
to a center and they're the kind of people, from the first conversation, they'll have us 100 questions. That this guy is not going to be happy if there's a small amount of extra pain, or if the person gets infected, he's going to give us hell. So then you gently encourage him to get out and go somewhere else. So we don't have to do all the surgeries. So we should do it for those people who are desperately poor, who will not go anywhere else, we are their last resort. I mean, we are their champions. The others who
Yeah.
can go elsewhere, go. If you think that that these guys are going to give us trouble, let them go. I don't know if that answers your question, Ravi, but
Hey,
that's the best
thanks.
that I can offer.
Yeah, definitely. Yes. Yeah,
Yeah, one has to
I
look
know
at
you have
the
a lot more to offer, but yeah, thanks. Yeah.
you have to look at the situation. And so we can see from talking to the patient, a very demanding kind of patient. Then we tell them, see, we can. This is what we can offer. And for example, we only have general wards
Yeah.
in our hospital. So the person who is well-to-do comes in and says, "Oh no, no, I want my surgery here." So we said, "Okay, why don't you go and check out the ward and now they come back." So they'll come back after seeing the general ward and say, "No, no, no, we want a private bathroom, we want a private room." Okay, so The way to keep your hospital, I mean, this is a discussion that we've had in our hospital recently because we're going to upgrade to a 100-bed hospital. So we had a big discussion whether we should have private ward or not. And the general consensus was no private ward. No private ward for two reasons. One, in a private ward, you can be seen easily by the nurse. If something happens to you, the nurse can immediately, it's under her vision. The ward is under her vision and she can quickly find out what's going on. If you're in a private room and
You
your
get to know.
bystander is sleeping, then you might die there. So that's one reason. And the second is that in order for you to have a private ward, you need much more nursing. There's got a whole lot of people to go and check on you. That's going to increase costs tremendously. So we've taken the decision not to have any private wards.
Thank you.
We can go with Doug's question now. You want to ask your question, and then we wind up.
I was just thinking about it, and I think we've had this discussion amongst ourselves quite often that just because a group of people are marginalized does not mean that they don't deserve the same standard and same quality of care that, I don't know, Ambani deserves or gets. Just because one has money and one doesn't mean that care should be different. Therefore, my question would be, how can we ensure quality of care, and how can we ensure that we are following guidelines, or like somebody comes with acute cholecystitis, you would say laparoscopic cholecystectomy, but in a lot of rural areas there is no laparoscopic facility. So how would you ensure that the same quality of care there are audits, for example, in medical colleges? That's also for us a kind of a safety net for when medical legal cases come. We can say that we provided the same quality of care. So how can one ensure that?
Well, we are living in two different worlds. Your world has quality. What about the world where there's nothing? So do you want quality where there's nothing? At least the person has an open cholecystectomy. Without laparoscopy, 10 years ago, that was a standard. You can still remove the gallbladder and save his life. The question here is, what is the quality that you would provide that saves this person's life? Now, if this person is going to have laparoscopic surgery, which means is going 200 kilometers away, it's not going to happen. He's going to go into sepsis and die. So what is the quality of your treatment? Your quality of treatment ended in a person dying. Because you said, oh, this person needs to have the same as Ambani. That doesn't work in our world. Do you mean to say that all our kids should go to Lawrence School, Lovedale, or to Rishi Valley? Is that going to happen? Who sets the quality of care? And what is this quality of care that you're talking about? Is it Western standards? What is the standard of our country? We have malnutrition of 30, 40, 50% in our country. I mean, our quality of care depends very much on the area you're in. If you're in Bombay or Calcutta, you can talk about these things if you have money. If you don't have money, do you think you'll be treated like Ambani? No chance. I mean, the real world is where you have money and you have influence, you get stuff done. Even a government hospital, if you have money and influence, you get stuff done. If you don't, so where is the quality of care? When you talk about audits in government hospitals, what audit takes place that is really transparent? Only recently we were called to work in a Taluk hospital. This is a few years ago before COVID. I was horrified. They had the cleaner wearing his regular cleaning clothes, standing there holding the suction for the cesarean section. He was not scrubbed. He was not wearing a mask. He was wearing his khakis, and he was in the operating room. This is in 2000s. So then when they asked us to do cesarean, we used to go there with all the equipment, all the linen, everything that was needed for the case. So what are we talking about? I mean, we are living in two different worlds. If you want to talk about quality, we have to talk about the quality of the person's, what quality can be offered for the person to stay alive. That's the first step. You're saying that let's become, postgraduates before we have, we pass kindergarten. The standards are very different. One has to look at the area one is serving and look at what is feasible, what can the people afford, Is the government providing it? If the government is not providing it, has to be some NGO that's providing it, and the NGO has to get funds to do these things. They have to get someone who's trained in laparoscopy. Why? Can't an appendix be done the old-fashioned way through a small incision, maybe about 2 inches, 3 inches? Okay, you don't have three small 1 inch incisions. You can do it very safely with a small incision. So one has to think of the end result. Am I saving this person's life? Uh, If I didn't do it, his quality of life would be very bad, or he would die. So one has to change one's standard to fit the situation one is in.
So, what would be your one last advice for young and aspiring surgeons?
I think you guys should go out and check it out. Check out stuff that's happening in our own country. Um, give it a shot for 3 months, 6 months, whatever. But don't miss the opportunity when you're still free and young and able to travel. And I can bet you it'll be a great experience. If not, you'll see a part of the country that you would never see otherwise. So go off to some remote part, see what these tribals are doing. What's different for the tribals? How are they different from us? Have you had the experience? We talk about all kinds of things of tribal, how welcoming they are, how they don't have, how they share, how they don't steal, they don't beg. Yeah, are those things really true? How are you going to find out? Unless you go out, check it out. And a huge part of your life, I would say, India is such a diverse country. I mean, it's such a, you have the wealthiest people in the world, and you also have some of the poorest people in the world. It's all here for us to experience. And I would say that this is a thrilling experience to go out, see what's happening. You don't have to commit yourself. You don't have to commit yourself. Just go see what's happening. So that's my advice. And for many, I think for those who venture out, it'll definitely be a change of heart. They may not work in a rural hospital, but will change their attitudes, the way they look at patients when they plan, and don't yell at patients because they've come late. They have to realize the challenges that they have to go through to just reach the hospital. So you become much more sympathetic to some of these poorer people who come, and you'll be kind of able to explain why they are, actually doing the things that they are doing. So I think you become a better person being exposed to rural areas and to the kind of need that our people still have. So check it out. Check it out before you get too old and get arthritis and atherosclerosis and the rest of it. When you sit and think when you're close to death and say, hey, that's one of the things I didn't do in my life. So get it out of of your your bucket list, if nothing else. It's going to be taking you out of your comfort zone. But what do you lose? You know, you're all going to live to be in your 80s. What the heck is 1 year? It's nothing. It's not even, how many percentages is it? It's like 1% of your life, maybe 2% at most. So it's such a small fraction of your life. Have some adventure. Go do it. That's my advice. I had a great time. I mean, I would say I would do it all over again if I had the opportunity and go to some remote area and see the change in 30 years time or 20 years time. There's so much change. There's so much has happened, which is so, I would say that as far as I am concerned, I would say that I would have been very unhappy if I didn't do it.
Thank you, sir. I think that brings this webinar to an end. Thank you so much for sharing with us your fascinating story and all the insights that you had to share. And thank you to everyone who joined us on this call this evening and for being a part of the conversation. We hope that today's discussion has been both informative and inspiring. If you have any questions for NK sir, you can email him or me at ruralhospitalnetwork.org@gmail.com, and we'll be happy to help in any way that we can. Our next webinar will be on the second Friday of next month, and we'll announce the theme and the speaker soon. So see you there, and have a great evening.
Thank you. Thank you all. Bye.